Good evening, everyone. Welcome to the masterclass session from Critical Care Medicine from the Yashoda Group of Hospitals. So this week we bring across a new case that is, acute exacerbation of COPD or asthma, which is pretty common, in this part of the time actually. So we have a case presentation by Dr. Muhammad Ali and Dr. Umar Bilal, who are doing their fellowship in critical care medicine at Yashoda Hospitals, Somajigoda. To moderate this, I am honored to welcome Dr. R. Vijay Kumar sir, who is a senior pulmonologist and a professor of respiratory medicine at Medicity Medical College, well-renowned faculty this part of the world. And we also do have Dr. Ashutosh Bharadwaj sir, who is a senior consultant and director of the critical care medicine, Dharmashila Narayana Super Specialty Hospital from Delhi. Welcome both of you, sir. So we'll proceed with the case presentation, sir.
Good evening, everyone. Myself, Dr. Muhammad Ali.
I'm Dr. Umar, sir.
So today we are going to present a case of acute exacerbation of COPD. So we had a 60-year-old male, a resident of Hyderabad, who presented with complaints of fever on and off since last 5 days, shortness of breath since 5 days, and cough which was productive since 3 days. Coming to the history of present illness, the elaborating cough was since 3 days associated with whitish sputum, which was non-foul smelling, no diurnal or postural variation, and a cough which is gradually progressive over the last 5 days. Shortness of breath since
Dr. Mohammed, can I stop you here? Can you tell me the importance of having the history of whitish sputum or now non-foul smelling sputum in a case of COPD specifically? Is there any significance of this?
Yes, sir. There is in case of COPD, there is an increase in the expectoration or the production of sputum in case of exacerbations.
And there is also increase of purulence, sir. Purulence of the sputum.
So purulence means it should be foul smelling.
Yes, sir, foul smelling.
So here you are saying that the patient had whitish sputum and non-foul smelling. So
Yes,
here we have to define what is the acute, what are you looking at this point of juncture?
Sir, we are looking at the production of sputum, sir, and that sputum has increased in its production, sir.
Increased from the baseline.
Yes, sir, increased from the baseline.
Okay. And whitish and non-foul smelling, maybe, he has contracted some infection which is not, bacterial, maybe viral.
Maybe viral.
That is the first impression you can have. Yes, please go on.
Shortness of breath since 5 days, initially grade 2 MMRC scale, which progressed to grade 4 MMRC scale over the last 2 days, which was not relieved by nebulizations and that the patient has taken at home, which is associated with occasional wheeze.
Okay. So, what is this MMRC score?
Modified Medical Research Council score, sir. So
Yes.
The score is 0 is no dyspnea, or grade 1 is dyspnea when the patient is dyspneic while walking uphill on the straight ground for a long time.
Yes.
Grade 2 is when compared to the contemporaries of his age group, the patient is dyspneic. Grade 3 is when patient is dyspneic when he walks around 100 meters.
And he stops for taking breath, sir. And the grade 4 is he is restless even on minimal exertion.
So he is bound to home maybe, huh?
Right.
Yes, good. Please go ahead. Dr. Vijay sir, if you want to add something.
Yeah, I'm just waiting for him to complete the clinical history, and then I want to see what is his clinical diagnosis.
Okay.
And then from there we can take the discussion.
Sure.
Fever 5 days ago, which was intermittent and it was not associated with chills, sir. And no history of chest pain, palpitations, orthopnea, PND, and decreased urine outputs. History of past illness, sir. Patient is a known case of COPD since 10 years on inhaler therapy. He was on LABA plus ICS combination since 8 years, sir. And he was on home bypass therapy since 3 years. And he had history of similar complaints in the past associated with frequent hospitalizations twice in a year in the last 3 years. And is a known case of hypertension, coronary artery disease on medical management. And he also had history of old TB in the past, sir, for which he took 6 months course of ATT.
Yeah, I think here we have very important information. That is, he has been having COPD for the last 10 years.
Yes, sir.
Which is remarkably good in the sense he did not have too many exacerbations. But in the past couple of, couple of years, or maybe last 1 year, he had 2 exacerbations.
Yes, sir.
Or twice in a year in the last 3 years.
Yes,
so what do you infer from this?
Sir, basing on the gold severity staging, which tells us that the ABE classification system, he falls under the frequent exacerbator group, that is E group of the staging systems are like the E system. The E group has more than one hospital admissions in a year, and he has more than two or equal to 2 exacerbations in a year, sir.
Excellent. So number of exacerbations and also severity of the symptoms.
Yes, sir.
These two things put him in the box E of gold guidelines.
Yes, sir.
So that means he has to be on very aggressive treatment.
Yes, sir.
And the treatment of COPD has changed a lot in the last few years. So anyway, when we come to the management, we'll talk about it.
Okay, sir.
And also your third bullet point, that is known case of hypertension or coronary artery disease, which is again a common combination for COPD patients. The COPD patients don't come as a standalone COPD. They usually come along with CAD, hypertension, and sometimes diabetes, sometimes history of tuberculosis, as it is in this case. And there is also what is known as a post-TB COPD. So
TOPD.
those who had, so post-infective, when there is excessive tuberculosis, which healed, that will produce the sequelae. Earlier, we used to call it as a tuberculosis sequelae, but now all COPD symptoms in those patients will qualify as one of the varieties of COPD.
Yes.
Good. Go ahead.
Can I add one point here, sir? So, patients who are having CAD on medical management, do you want to take any specific history in terms of drugs with respect to the patient's history of COPD?
Sir, usually if we have to take history regarding is he taking any beta blockers or ACE inhibitors, because they tend to increase the cough, sir.
Yes, please go.
So personally,
anyway, as compared to asthma, beta blockers are not contraindicated in COPD. In fact, if they have a coronary artery disease where a beta blocker is required, he has more benefits because of the beta blocker than any perceived disadvantages. So we have a beautiful paper which has been published quite some time back in JAMA, where it talks about beta blockers in COPD patients.
Personal history, sir. He's an ex-smoker. He used to smoke for 30 long years, and he used to smoke 2 pack per day, sir. And he has disturbed sleep. He had normal appetite. He had normal bowel and bladder movements, and his diet was mixed, sir. Sir, can I go to the next slide?
Yeah, again, I think this is a very important part of the history when you talk about mixed diet, because what we find is patients who are COPD and who are vegetarians, they have two major issues. One is they are short of proteins in their diet, and second is they are deficient of vitamin B12, because most of the vitamin B12 is in the non-vegetarian food like eggs, meat, chicken, and fish. So whenever such a patient comes for an exacerbation or even for a consultation in the outpatient, we have to make sure that we advise them to take sufficient quantities of protein. For vegetarians, we normally advise soya and paneer and other legumes and also nuts. And vitamin B12, for this particular patient who got admitted in the hospital, we have to give one loading shot of vitamin B12 as soon as he's admitted in the hospital in the casualty itself, and maybe even a loading dose of vitamin D3. So there is the importance of asking for a mixed diet in a case of COPD.
Yes, sir.
In the ER,
Again, when you said normal bowel, etc., because many of these smokers, they not only have COPD, but also they are a high risk for malignancies, especially carcinoma colon. So if they have CA colon, then this bowel, normal bowel movements will not be there. They will have alternating constipation and loose motions and pain abdomen, etc. So one of the important things that we need to rule out in these COPD patients is malignancy, either in the lung or elsewhere in the body.
Yes, sir.
Okay. In the AR, in the AR, patient was on presentation. The patient was restless, drowsy, but arousable, and had breathing difficulty. Saturation on room air was 74% at presentation. Blood pressure was around 130 by 80 mmHg, and the respiratory rate was about 42 per minute, and heart rate was around 140 beats per minute. So patient has been started on oxygen support with a simple face mask at 10 liters per minute. ECG was taken in the ER that showed tachycardia, and the ABG taken at the ER showed a pH of 7.18, a PCO2 of around 83, PO2 of 184, and a bicarb of 32.4 millimeters.
So what is your inference from this information?
Sir, sir, the patient, with regards to the vital, sir, he has tachypnea and tachycardia. And with regards to the clinical condition, he has respiratory distress and he has breathing difficulty. And with regards to the ABG, sir, it's suggestive of respiratory acidosis, sir.
Yeah, regarding bullet number 2, anything extra you want to say? See, the pulse oximetry, the pulse oximeter gives excellent information. Here we have a saturation which is 74%, and the heart rate is 140. Let us assume that the saturation is 74%, but the heart rate is, let us say, 90. What do you infer?
He is a chronic case of COPD, sir. So
Excellent.
tolerant.
Correct. So the very fact that it shows a tachycardia in the presence of hypoxia means it's an acute presentation and not a chronic one. And secondly, I would hesitate to put him on such a high amount of oxygen, that too with a face mask. Nasal prongs, starting with 2 liters, should be good enough because our goal is to achieve a saturation of 90%.
Yes, sir.
Because 90% is equal to PaO2 of 60, which is good enough. We don't want to overshoot, just 90%. So you will not know whether you have crossed 90 or not when you give 10 liters per minute with a simple face mask. The best interface is a nasal cannula.
Regarding ABG, how do you proceed with the ABG?
Sir, with regards to ABG, first we should evaluate whether it is acute respiratory acidosis or is it acute on chronic respiratory acidosis, whether it is chronic respiratory acidosis. And by using a modified Hasselbalch equation, we can detect what it is the etiology, sir, whether it is acute and acute on chronic or chronic, sir.
The first step is to check the validity,
Validity, sir.
which you told, yeah, the Henderson-Hasselbalch equation.
Yes, sir.
So suppose this is a valid ABG. Now how do you proceed?
Sir,
What do you see in the ABG first? What is your diagnosis with this ABG? Let us.
sir, it falls under acute and chronic respiratory acidosis, sir. The
Acute
change
and chronic.
Yes, sir.
And how do you see that?
Sir, we use the formula, the change in H plus ions by change in carbon dioxide, sir.
So
And
here, the CO2 expected, what is the normal PCO2?
40,
Suppose
sir.
it is 40. So
40.
now there is increase in the PCO2 of around 40.
40.
So what would be your expectation as far as the pH is concerned? Here,
With every
is it falling in the acute or chronic compensation?
Chronic, sir, because with every 10% increase in CO2, the bicarbonate should increase by 4, sir.
4. And what is the bicarbonate?
32, sir.
32.
32. So now you have reached to a diagnosis. What is your diagnosis?
Acute on chronic respiratory ACMO.
Okay. And the reason is acute exacerbation of COPD.
Yes, sir.
Is it?
Yes, sir.
Yes.
So what are the common causes of this acute exacerbation in these patients?
First one is the infection, sir.
Viral infection.
Any viral infection or the bacterial infections background. Second thing,
What are the
patient
common bacterial infections when we receive these patients from the community?
Haemophilus influenza is the common organisms, the most common
Yes.
organisms.
And Streptococcus, maybe Moraxella,
Like, sir, more
then viral infections.
Viral infection.
But yeah, so around 70% of the patients will have infections as a trigger. And what are the other triggers?
The other is he can be again exposed to pollution or
Yes.
cigarette smoke, or smog can be in the irritants or some.
So very common is, the sir will be telling you better because he's a practicing pulmonologist. We are basically intensivists, but a lot of patients I see in ICU, they present to us after they, have been non-adherent to the therapies, defaulters of the therapies. That is one very common thing. Or maybe patients who are on home oxygen therapies, they, sometimes oxygen toxicity. Maybe, if the disease is advanced, bullous disease, you can have these patients presenting with spontaneous pneumothorax. Advanced cases will have some or the other effect on the heart, mainly the right side of the heart, especially pulmonary hypertension. There you can have patients presenting with some kind of heart failure also. So, heart failure again can be a trigger for this exacerbation. So you want to add something more?
Yeah,
Yes, sir.
excellent. But by definition, exacerbation is these three things: sudden increase in the last 14 days of cough, expectoration, and breathlessness. And very nicely, you have summarized the other things, which are all actually the complications of COPD, like pneumothorax or right heart failure, etc. But one should keep all those things in mind whenever we approach a case like this.
Okay, sir. Sir, shall we proceed?
Yes, sure. So again, Bilal,
Sir.
just go to the previous slide. The very fact that the first bullet shows that the patient was restless and drowsy itself shows that probably his CO2 is high.
Yes, sir.
Yeah,
Yes, sir.
restless and drowsy. So CO2 is high because CO2 is a narcotic inside the body.
Yes, sir.
So whenever it crosses 45, then they start having the manifestations of hypercarbia. So that itself should alert us and that itself shows that the PCO2, PaCO2 is higher than 45. And now that SpO2 is 74, it only means that PaO2 must be much less, somewhere around 45 to 50. And the heart rate, which is 140, shows it's an acute presentation. So without doing any investigation, we are getting a lot of information just by looking at all these, looking at the patient, looking at the pulse oximeter, etc. And we should be extra cautious not to increase his oxygen levels, because there is patient is surviving on his hypoxic drive. We have to remember that. So we have to maintain that hypoxic drive. Once you knock off his hypoxic drive, then the patient will go into a respiratory depression.
Yes, sir.
Yeah, go ahead.
Chest X-ray taken in the ER showed by hyperinflation. So after that, the patient was immediately, after seeing the ABG, patient was immediately started on NIV support and was shifted to ICU for further evaluation. And in the ER itself, he was started on antibiotic cefoperazone sulbactam combination, 1.5 gram IV BD, clarithromycin 500 mg BD, and oseltamivir 75 mg BD, and a injection methyl prednisolone 40 mg OD, and Clexane, injection Clexane 40 mg subcutaneous ODs. And on nebulizations, formoterol, budesonide, and glycopyrrolate.
Okay, great. So you mentioned about hyperinflation in the chest X-ray. Why do you say that?
Sir, because there is increased lucency in the lung,
Okay.
and
Are the diaphragms flat?
not completely flat, sir.
They are not.
Completely flat.
They are
Is the heart shadow narrow?
No, no, sir.
No,
No.
no. So these are the two very important factors to call it as a hyperinflation, a narrow heart and a flat diaphragm, which in this case is not there. So probably I would not venture to say it as hyperinflation. That is how most normal X-rays look like. But we can gather one more information, and that is patient doesn't have any patch of pneumonia anywhere.
Yes,
Yes.
sir.
Okay.
No.
So in such a situation, there are two P's we have to remember. One is pneumonia, and as a pneumothorax, as Dr. Ashutosh Bharadwaj has rightly said, rule out pneumothorax and rule out pneumonia. So here, both of them are not there. So we are happy. So we don't have to be too aggressive on the antibiotics, because whatever bacterial infection happens, which Dr. Ashutosh rightly mentioned, it happens in 70% of the times. The bacteria, where does it come from?
It is mostly the environmental bacteria.
No, they are from the nasopharynx.
Nasopharynx.
Yeah, they are from the nasopharynx. They're already there in this patient. Only thing is, it was colonized, and suddenly they start multiplying, and then they gravitate, they get aspirated into the tracheobronchial tree, and then cause the infections. So what are these bacteria already discussed? Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. So they are our friendly bacteria. They're friendly bacteria. They have been residing in the nasopharynx, oropharynx for very long time. You don't want to kill them with a very huge machine gun. Is it not?
Yes.
Okay.
So as per the gold guidelines, a simple antibiotic would be enough, such as amoxiclav and clarithromycin, or if the patient has come in respiratory failure, probably you may want to put him on a respiratory quinolone. Otherwise, better not to waste our antibiotics, because whenever we are treating any case in the ICU, not only we have to get good results, but also we have to treat the patient economically. When I say economically, it means we have to do only the most necessary investigations because investigations cost a lot. And we have to give the most economical medications because higher antibiotics are more expensive. So somebody said, why not azithromycin instead of clarithromycin? Because in acute situation, clarithromycin is better because blood levels are reached faster, although it doesn't have a post-antibiotic effect. It has a very good MIC, especially it has got a very good action on Streptococcus pneumonia and also atypical bacteria.
Yes, I also agree with sir. You will not like to have so much of antibiotics.
Correct.
Maybe coamoxiclav would be a good choice. Maybe clarithromycin. So in respiratory patients, this is a macrolide which we prefer. Can you tell me what are the reasons that we prefer macrolides
Sir,
in respiratory?
because they have anti-inflammatory effect and
Also,
immunosuppressive effect.
very nice, excellent. And why did you choose oseltamivir? Was
Sir,
there
because
any?
since the current season we've been getting a lot of cases of flu, so that's why prophylactically we have added oseltamivir, sir.
Yeah, I would also like to add one point here, just as an extension of what Dr. Vijay sir was telling you in context of the hypoxic drive. What is the other reason, very important reason, that we don't use much oxygen here? And the target of SpO2 maybe is 88 to 92. So one is the hypoxic drive, which sir was.
Second is the
discussing.
Haldane effect, sir, and one is the Bohr
Okay,
effect, sir.
very good. What is that?
Bohr Haldane effect is whenever we give excess of oxygen, there is unloading of carbon dioxide since the hemoglobin has more affinity towards oxygen. So there is an increase in the PaCO2, arterial CO2.
Perfect. So deoxygenated blood carries more CO2. So the chances of accumulation of carbon dioxide is not there. Okay. Now you shifted your patient to ICU from ER. Now, what are those points? Can you enumerate what are the indications of getting this patient admitted in ICU? When do you straight away go in the ER, you assess your patient, you see some things, and you say that now this patient has to be in the ICU.
The patient was too restless, sir. He was drowsy first on examination, and third on examination he was too tachypnic since his respiratory rate was too high, and
So severe dyspnea,
severe
dyspnea with accessory muscle use,
and severe hypoxemia, and
hypoxemia.
ABG
Yes.
suggestive of respiratory acidosis, sir. Acute and
Very good.
respiratory.
Excellent. And then some kind of altered mental state also this patient was having. The other reasons may be the the hemodynamic instability. Those are the very common things that you see in the ER patient, and then you decide about that patient shifting to ICU. Okay, we can go ahead. Yeah.
Okay, sir.
General examination in the ICU. Patient on presentation was drowsy, arousable to the verbal stimulus. Patient was tachypnic. There was no pedal edema, no pallor, icterus, or clubbing or cyanosis was seen on examination. And as patient was on NIV support, he was sitting restless in a tripod posture, tripod posture, and his weight was around 55 kg, sir, and the temperature and presentation was 98.7 degree Fahrenheit. The pulse rate was 125 beats per minute. Respiratory rate was around 42 per minute, and the saturation on saturation 78%. BP was 115 by 70 mmHg.
78 after giving oxygen?
Sir, sorry.
Sir,
You have already given 10 liters per minute.
yes, sir.
So,
It's typing error, sir.
And the
Okay.
previous AVG was showing very high PO2 levels.
Yes, sir.
So with that PaO2, you should be having 100%.
Yes, sir. Yes, sir.
So that means we have given more than what he needed.
Yes, sir.
Yes.
Right. So we were talking about the antibiotics. We know that some of the COPD patients need a Pseudomonas cover.
Yes, sir.
Yes.
Which are the patients who need a Pseudomonas cover of antibiotics?
Since in this patient, he had a history of tuberculosis as well, sir. So we might suspect some structural abnormalities such as bronchiectasis, parenchymal
Okay.
bronchiectasis can be present, which can be a source of which can be a good medium for Pseudomonas.
Okay.
And
And
second,
anything
patients
else?
who were already admitted in hospital, if
He
there is
had
any
history of frequent hospitalization. So, Pseudomonas is the most common bacteria which is present both in structural lung diseases and with regards to COPD. So that's why we have added a anti-pseudomonal antibiotic which had a good action, sir, like ceftriaxone plus sulbactam.
Yeah. So post-tuberculosis bronchiectasis doesn't qualify as a bronchiectasis because it is mostly in the upper lobes. That is why it is called bronchiectasis sicca. That is, it's a dry bronchiectasis.
Dry bronchiectasis.
Only bronchiectasis which is in the middle and lower lobes will be wet bronchiectasis in the sense where there is a lot of stagnation of mucus secretions and frequent infections and things like that. Gold guidelines mention four things for Pseudomonas. One, the severity of COPD, where FEV1 is less than 30%. And number two is bronchiectasis in the middle and lower lobes. And number three, chronic steroid use for some reason. Maybe they are having connective tissue disorder or maybe having some other indication where they are using it. And the fourth is in the recent times, the patient has used a broad spectrum antibiotic in the past 3 months. Then he is a more likely candidate for Pseudomonas. In that situation, which antibiotic would you prefer? We have seen the X-ray. There is no pneumonia. What is your preferred anti-pseudomonal in this situation?
Sir, amoxicillin plus clavulanate.
Amoxi doesn't cover Pseudomonas.
Sorry, sir.
piperacillin tazobactam.
Yes, it covers, but is there anything less?
Sir, ceftriaxone.
Ciprofloxacin. Ciprofloxacin is the best. But if you see, he has got a lot of pneumonia or a lot of his sepsis sort of a situation. And as I mentioned, those four factors, then you can go for a higher anti-pseudomonal cover. Yeah, great. Go ahead.
Systemic examination, use of on examination, patient was using accessory muscles of respiration. There was intercostal and subcostal retractions, and a paradoxical abdominal movements is seen, and the chest expansion was reduced bilaterally, and auscultation, the decreased breath sounds with expiratory wheeze was heard, and there was no murmur. Per abdomen on palpation was soft and non-tender. There was no focal neurological deficit.
That's all. General examination.
Yes, sir. Sir, and on percussion, there was a resonant note, sir.
On what?
Percussion, sir.
What did you find?
There was a resonant note, sir.
Resonant. Okay, fair enough. Okay. So you missed one slide. General examination is over.
Yes, sir.
Okay, right. So here you are mentioning, just keep that slide. You mentioned about no pedal edema. Anything particular with regards to pedal edema in this particular patient?
Sir, because since he is a long-standing of COPD, long case of COPD, he can probably have a core pulmonary, which is in those cases, pedal edema can be present, sir.
Correct. So you would look for JVP, you would look for
Hepatomegaly,
tender,
tender
enlarged liver, hepatojugular reflux, and also pedal edema, which signifies a right heart failure.
Yes, sir.
Fine. You have to keep that in mind, even if it is not there. Fair enough. Please go ahead.
So, sir, if you allow, this patient you have kept on NIV. So, can we discuss about NIV here?
Yes, most
Yes,
important.
sir.
Very, very important. I think they is going to discuss now about NIV.
Yes, sir. Yes, sir. In the coming slides.
In the coming slide.
You are coming.
Okay, perfect. Please go ahead.
So after examination, we came up to the differential diagnosis of first one is the acute exacerbation of COPD, sir. Second one was pneumonia, and third one was the pulmonary embolism, and fourth was heart failure.
So how could you rule out pulmonary embolism in this patient? They also have hypoxia.
But there was a type 2 respiratory failure, and historically the patient was fitting into a COPD exacerbation.
But then COPD people also are candidates for pulmonary embolism.
Yes, Iris.
Yes, sir. But the classical S1 Q3 T3 pattern was not seen in the ECG, sir. The ECG was suggestive of sinus tachy.
Okay.
And
So, can I stop you here? What is the most common finding of pulmonary embolism in an ECG?
is sinus tachycardia with RBBB, sir.
So that's what you told us. Sinus tachycardia is the most common ECG finding in cases of PE. S1 Q3 T3 is a classical thing, but it is rarely seen. So sir is very right that this strong DD is PE also, pulmonary embolism. So how can you rule out?
Further, we did a 2D echo, sir. So that was suggestive of RA and RV were normal. So in case if we suspect a massive PT, so there can be RA RV dilation. Second is the PAH was also the mild. It was a mild PAH, sir. So
okay.
And also when he came to the casualty, when you gave him oxygen because he was hypoxic, the moment you gave oxygen, his saturation improved, which will not happen in pulmonary embolism.
Yes.
Yeah, because of the shunt.
yes.
So whenever oxygen doesn't improve, after giving oxygen, you have to have that doubt. Of course, you will confirm that by doing more investigations at a later time. But that would be the initial impression, where giving oxygen doesn't improve the oxygen saturation. Go ahead. Very nice.
So POCUS in the ICU showed a bilateral A profile, sir, and there was no pleural effusions. IVC was collapsing, and there was no evidence of any shred sign, and no signs of no RA-RV dilation, and a good LV function.
Okay, so you talked of POCUS, huh? And you showed us the A profile. So how do you further dissect this A profile? A profile does not mean acute exacerbation of COPD.
Yes, sir.
What else can you have when you have A profile? Or can we start, what is A profile or B profile?
In A profile, we can pick up, and if there is any while doing an ultrasound, we assess whether there is a lung sliding or not, sir.
Yes,
First,
very nice.
then we see the profile, like whether it is A profile or B profile. If it is A profile, then we look for any shred sign or any signs of consolidation, which
No,
indirectly.
first you will have to see you will have to do the venous analysis. If you find thrombosed veins, then it indicates towards maybe pulmonary embolism.
Yes, sir.
Sense that when you have free veins, then you have to have those signs, the shred sign or plebs, what you call plebs. If you have those signs, you have pneumonia. Otherwise, now you are quite sure without these that you are really dealing with the patient of COPD or asthma. Okay, very good. Please go ahead.
ABG done in the ICU after 1 hour. Patient was still tachypnic, sir, and his drowsiness worsened. And he had on examination, heart rate was around 146 beats per minute, and the respiratory rate was around 40, and BP was 140/80 mmHg. And the repeat ABG that we have done after 1 hour had showed a pH of 7.07 and a PO2 of 192 and PeCO2 of around 120 and a bicarb of 39, sir. Taken with an FiO2 of 0.4 and a PEEP was around 5 and the PEEP was around 5. Sir.
So, patient was on NIV.
Yes.
Okay.
So this is where we are coming to the most important area, which Dr. Ashutosh was mentioning, that is about NIV. On an average, in India, we have some 6 crores of COPD patient, and every COPD patient, on an average, will have at least one exacerbation. Some will have 2, some will have 3. So it is quite likely that in any hospital, there will be one acute exacerbation of COPD patient who is coming into the ER. And this is where NIV plays a very big role. If you can manage a patient of acute exacerbation of COPD with NIV successfully, you can manage any patient. It's like your acid test. So here, as Dr. Ashutosh mentioned, we need to have some discussion about the NIV. What did you do? What mask? What pressures, etc. We need to discuss.
Indications, contraindications.
Yes, sir. Coming to the indications of NIV, sir, grade 1 indications is like any pH falling below 7.35 and increase the PCO2 of more than 45, sir. And pulmonary edema. And we also have cardiogenic pulmonary edema. So these are the grade 1 indications of NIV, sir.
Yeah.
So, if I may improve this, so as you are telling, there are 4 grade A, grade 1 indications of NIV. First you told is the COPD exacerbation.
Yes, sir.
The second one is when you extubate a patient,
Yes, sir.
as a bridge after extubation, NIV is grade 1 recommendation, indication. The third one you mentioned is cardiogenic pulmonary edema. Again, there the role of CPAP is more. And what is the fourth one? Again, very important.
Patients
And
who are
this
immunocompromised.
very nice. Very nice. So hypoxemic respiratory failure and immunocompromised. These are 4 grade 1 indications. And what about what the sir was asking, Dr. Vijay sir? What are the indications with respect to COPD patients? This is our question. When do we put COPD exacerbation patients on NIV?
When the patient is drowsy, sir, first on examination, starting with the examination, when we see a patient who is tachypnic and who had increased lack of breathing, while when we see a patient using his accessory muscles or with the increased volume of breathing, then ABG, when it is suggestive of respiratory acidosis, uh, and when the patient is drowsy but erosible, sir.
So maybe you have to have a patient who is not that drowsy. So in classical literature, you have to have an alert and cooperative patient for NIV. But the story is little different here. So the sir will agree that all those patients who we know that will maintain the upper airway very well, we will try to give a fair trial of NIV to those patients, chronic patients. So yes, these are the indications. Okay. And how do you approach this NIV therapy? How do you, ask your patient to have it? How do you proceed with the NIV therapy? You straight away, order the nursing staff that this much of pressure is required, so just put the patient on NIV.
No, sir. Starting with the face mask that we use a non-vented mask, and based on the patient's facial build up, so there are different sizes of masks which are available. So to prevent excessive leak, we use a proper we measure it from the bridge of the nose, nasal bridge to just above the chin. And first one is non-vented mask. Then we
use a oronasopharyngeal type of mask, sir. Oronasal type of mask.
oronasal mask.
So first thing is that you talk to the patient. You try to convince the patient because the patient may be not in an accepting mode. So you ask the patient that this is a kind of therapy where if he is not used to it, that this is a kind of therapy where some kind of air will be pushing out of the device, and you just have to keep yourself in accordance with that flow, and that will help you. You have to counsel the patient that this is what we are going to do with you, and then maybe hold the mask close to the patient's face. Maybe ask the patient that just hold this mask for 10 minutes and let's see how it comes out, and you will feel comfortable. So gradually like that, you will go ahead and not too tight when we apply the mask. First loosely, and then maybe tight as per the requirement, not too tight, because a lot of times long-term applications will cause the nasal bridge necrosis. So little loose, but again, this cannot be as loose as in the home BiPAP we use, because the leak compensation in the IC ventilators is not that much. Okay,
Yes.
so this is how you approach. Dr. Vijay, sir?
Yeah, totally agree. Totally agree. Most important is the patient should be taken into confidence. We have to explain what we are going to do, and you have to sit next to the patient. Make yourself, very, friendly posture, and then tell him that this is a face mask which is going to produce a lot of gush of air, and we have small, medium, and large. So normally all adults will require large. Nasal oral face mask is good enough. And initially we don't tighten the belts, we only just hold it. And if the patient can hold it himself, good enough, so that he feels he is in control of things. And then when we say NIV, we are talking about the two pressures, the inspiratory positive airway pressure and the expiratory positive airway pressure. And usually the inspiratory positive airway pressure is in 2 digits, double digit,
Yes, sir.
whereas expiratory positive airway pressure is in single digit.
Yes, sir.
And one look at all the literature that's available where NIV has been used for acute exacerbation of COPD. Starting from Brochard in 1995, who published the first evidence that NIV works. That was in 1995 in NEJM. And then, of course, came the bigger study of Plant, where he published a beautiful paper in Lancet. And also there were another 10 or 12 people who have published their experiences with regards to NIV in acute exacerbation of COPD. If you look at all the pressures which they have used, most of them have used a IPAP of something like 12 to 15, and EPAP never exceeded 5.
Yes.
So one of the important takeaway from this is never ever increase the EPAP, because that will produce um, air trapping
Yes, sir.
and dynamic hyperinflation, decreased venous return, and hemodynamic um, problems. And patient will go into hypotension, and you will say that the NIV did not work. So make sure that the EPAP is 1/3 of the IPAP. That is a rule. And as Dr. Ashutosh rightly mentioned, never tighten the straps too tight. So we use what is known as a two-finger rule. So you put two fingers just near the temple and then put the straps very gently. That way, you know that it is not too tight. And certain amount of leak is acceptable, up to 15% to 20%, because the newer models of NIV machines are capable of compensating for the leak. So don't worry about the leak, even if there is a little bit of it. And why I'm saying IPAP should be more and EPAP should never exceed 5 is because the difference between IPAP and EPAP is the pressure support. And pressure support is the one which is going to generate the tidal volume. Tidal volume multiplied by the respiratory rate is the minute volume. Bigger the minute volume, greater is the washout of carbon dioxide. If the carbon dioxide is increasing in spite of your NIV, it means patient is not getting enough minute volume. So you have to increase the tidal volume. To increase the tidal volume, we have to increase the pressure support. To increase the pressure support, we have to give a big gap, big difference between IPAP and EPAP. So you can only increase the IPAP, but never increase the EPAP, because EPAP in NIV terminology, it is EPAP, but in ICU terminology, it is the PEEP. When the PEEP exceeds the auto PEEP, then all the issues will start. So I see that this patient has failed the NIV. That's the reason why he had to go for intubation and ventilation. So maybe something went wrong in selecting the pressures. And rightly, somebody mentioned in the chat box that the time to put the patient on NIV is when the pH is between 7.25 and 7.30. That is because most of the studies were done using this parameter, but then that doesn't mean that we cannot put a patient who has a lower pH, because those pH, lesser pH were actually excluded in those studies. That is why they are not part of the indications. So always use this rough rule. EPAP should be should be 1/3 of the IPAP, and it should never exceed 5. EPAP should never exceed 5.
Okay.
Now tell me, what are the pressures used for the NIV in your case?
PEEP was around 6, sir, and pressures up PC above PEEP was around 14.
PEEP.
Sorry, sir. EPAP was around 6 and IPAP was 14.
Okay, fair enough. Okay. So something like 15/5 would satisfy that rule of 1/3. I don't know why the patient failed the NIV, because this seems to be 15/5 seems to be a good pressure, supposed to generate good pressure support, should wash out carbon dioxide. And then did you come across a terminology called AVAPS?
Yes, sir.
What is it?
Mid-rate volume, adjusted pressure,
Average volume.
adjusted pressure support ventilation.
Average volume. So what happens is here you select the target volume, target tidal volume or target minute volume, and then machine would, if the tidal volume is less in one breath, it will calculate the tidal volume for the 2 or 3 previous breaths, and it will increase the pressure automatically so that it can increase the pressure and it will increase the tidal volume. Ultimately, at the end of um, 2-3 minutes, it will be able to come to that target tidal volume or target minute volume.
Okay.
Ideally suited for COPD. So AVAPS is a term which is used by one particular company, whereas other companies are not allowed to use this term AVAP. So they use different terms like target volume and things like that.
Okay, when would you start invasive ventilation? When would you say that the patient has failed the trial of NIV? For how long it should be tried? What are the features or the findings on the basis of which you will defer the NIV and take your patient on invasive ventilation?
We usually give a trial of 2 hours. After that, we repeat an ABG and we assess the clinical condition of the patient. If the work of breathing and his sensorium improves, then we continue with the NIV trial. Otherwise, if there is tachypnea is still persistent and he's still drowsy and the ABG is suggestive, shows any decrease in the pH or increase in the PCO2 or worsening, then we opt for mechanical ventilation.
Okay, so NIV failure, okay. Or patients on NIV who starts having cardiovascular instability. Those patients again should be taken on invasive mechanical ventilation. Some patients can have massive secretions and they cannot protect airway. Also in such cases, this is a practical problem which we all see in the ICUs. And some patients, like the place where I'm working, 30% of the patients are from the oncology background. So onco patients also have COPD. So head and neck surgery patients, post-operative status, you will have a lot of deformities. Sometimes, facial trauma. So facial disfigurement will not give you a chance to apply, NIV. So that can be also taken as a contraindication to NIV. So now you moved and you decided to intubate your patient, is it?
Yes.
Yes, sir.
So how do you proceed as far as intubation is concerned in ICU?
Sir, we usually do a rapid sequence intubation, sir.
What is that?
Sir, both sedation and analgesia are given very rapidly to avoid any aspiration or to avoid any hypoxemia, sir. And it is usually done in a very shorter durations.
Okay, no. So, you have to use the fixed dosage of the drugs which you are using. And rapid sequence intubation is always done with the cricoid pressure on.
Yes, sir.
So those things are the two things are the hallmark when we talk of rapid sequence intubation. Whatever agent you choose, it's your choice. You have to apply cricoid pressure so that aspiration is not there. Okay. Now agents, which is the good relaxant if we talk in terms of the COPD patient, when we talk of these muscle relaxants?
Non-depolarizing muscle relaxants such as curenin, vecurinin.
Which one will you not like to give? Okay.
Ketamine, sir.
So, I'm talking of the muscle
Yeah,
relaxant.
sorry.
So maybe extracurium because of the histamine release.
Yes, sir.
Okay. And you talked of ketamine. What is so special of ketamine? It always comes whenever we talk of COPD.
It can cause bronchospasms.
No, it is an induction
Dissociative
agent
anesthesia.
which causes bronchodilation.
Bronchospasm.
It is good in such patients. In those patients where the blood pressure is less, it causes increase in the blood pressure. Now, important point here is that with experience you learn that intubating patients in ICU or in ER is very different from the intubation we do in the OTs. Okay, because such the patients like we have here will be very sympathetically charged, and the sympathetic drive is lost once you use too much amount of anesthetic agents, and there is sudden fall of blood pressure. So you have to titrate the agents. That is very, very important. Very, very important. You have to be ready with the vasopressors as well as the fluids during intubation.
Yes.
Okay. So all those things you keep in mind. And one very important thing is the size of the tube here in such patients. Because maybe you will require to do the valve.
Yes, sir.
And then larger diameter of tube will have less resistance. Resistance is an issue in such patients. In weaning, in ventilation, in knowing the procedures during the time the patient is on ventilator. All those things will be facilitated when we have large bore tubes. So all those things we should be kept in mind. Dr. Vijay, sir.
Very good points. Very good points. So initial 1 hour is when they need 1 to 2 hours is when they need a bit of neuromuscular blockers, but eventually we can control and get the ventilation done with sedation, and then once the CO2 is washed out with a good tidal volume, um, probably from volume control, we can switch to SAMB with pressure support, because we need to get these patients out of the ventilator as fast as possible, because otherwise, they are sitting ducks, candidates for getting ventilator associated infections. Dr. Ashutosh, you have to forgive me. I may have to leave because there is another webinar for me starting at 8 o'clock. So I require your permission to leave this webinar.
Sir, no issues.
Yes, thank you. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, Ravi Shankar, and thank you, Venkat.
Thank you, sir.
Thank you, sir.
Thank you, sir.
So yeah, we will proceed. So Dr. Ravi Shankar, if I may ask, maybe in next 10 to 15 minutes, we'll try to wrap up.
Yes, sir.
Okay. Thank you.
Patient was intubated using fentanyl and rock in view of NIV failure with regards to Haggard score of 18, and he was connected to a ventilator. Initial settings of volume control mode with a tidal volume of 400 ml, respiratory rate of 18, PEEP of 6, and an FiO2 of 0.4, and an IE ratio of 1:3 was set.
So we can talk about the settings, invasive ventilation settings here. So first we need to understand what are the goals we have in our mind. What are the goals like we have in ARDS, that we want to keep our PEEP rate low. We want to have the PEEP and FiO2 ratio. We want to have we want to minimize the some injuries. So what are those things which you should keep in mind when you are ventilating patients of COPD? What are the goals?
First one is adequate ventilation, sir. We are the tidal volume that we are giving, the inspiratory and the expiratory tidal volume. First, we'll see. whether the settings what we have kept on that, based on that patient is adequately ventilated or not. Second one is we want to give more expiratory time to these patients, since there is a
Excellent.
so in view of that, the inspiratory and expiratory ratio of 1:3 was selected, sir. And a minimum of oxygen support, like FiO2, what the patient is tolerating, like with the target of SpO2 of around 88 to 90. The patient is the minimum amount of FiO2 that is required to maintain that saturation.
Yes, very good. And one very important aspect of ventilating such patient is that we do not want to have much of auto PEEP. We want to prevent barotrauma, dynamic hyperinflation. So mode, what is the preferred mode? You have chosen the volume control mode. Is there any reason behind that?
Sir, because volume control will reduce the risk of barotrauma. It will maintain consistent tidal volume, sir, and it will it can also prevent auto PEEP, sir, which thereby preventing dynamic hyperinflation, sir. So that's why volume control also has a sine wave flow pattern, sir. Contemporary
Yes, that.
pressure control that has a decelerating pattern. So
Okay, yes. So that causes some changes in the expiratory time.
yes, sir.
So this is the preferred volume assist modes classically. But as nowadays in most of the ICUs, tertiary care ICUs, we are using dual modes.
Yes, sir.
So
PRT.
this debate is little not that on nowadays, but yes, theoretically perspective, we can go for the volume assist modes. Now the target is also to have adequate expiratory time. So prolonged expiratory time. Now you have set 1:3. What is the maximum you can go?
1:5, sir.
Yeah, so 1:3 to 1:5 you can go. Start with low respiratory rates. What is the reason? So as to have
prolonged expiratory time.
Prolonged expiratory time. Okay. And what about the inspiratory flows? If you have an option to set, what would be your choice?
Sorry, sir.
Inspiratory flow. Inspiratory flow. You will like to keep it little higher. Maybe, start with 60 to 70 liters per minute.
Okay.
Now, higher inspiratory flows will lead to less inspiratory time and again will impact more on the expiratory time. So, higher inspiratory flow means lower inspiratory times and higher expiratory times. Okay. And how much PEEP? Yes. And how much PEEP?
PEEP we should be keeping around on the lower side only, sir. Around PEEP 4 to 6.
So there is no fixed PEEP, but you have to use it cautiously. Whatever PEEP you use, you also have to see if there is any amount of auto PEEP the patient is generating. How can we know that?
Sir, by asking the patient to do we do a expiratory hold, sir. It is a maneuver.
Expiratory hold.
Thereby, the flow volume curve will not touch the baseline, sir.
Very good. Very good. The flow, which flow time?
Yes, sir. Flow time.
Okay, so this is a scalar which you see on the ventilator. So the baseline will not, the expiration will not touch the baseline. That you know that the patient is having auto PEEP. And once you calculate the auto PEEP, now how do you set the PEEP?
In a sedated and a paralyzed patient, sir, we see that whether the breaths, patient triggered breaths are been and ventilator triggered breaths and patient triggered breaths, whether they are matching or not. Whether
Okay. So suppose you have an auto PEEP of say 20. What would you do? Would you like to counter this with something?
we'll
by setting the PEEP.
PEEP, sir.
So around, yes.
2/3 of the auto PEEP, sir. The PEEP
At least, yes.
2/3 of
Very good. Very good. I think we have covered this. So we can move ahead.
An HRCT test was done to rule out the process and also to assess the level of structural damage to the lungs. And on day one, the patient was investigation showed a hemoglobin of 12.1. A TLC count was around 9,800, and platelets were around 1.7 lakhs. A serum sodium value of 135, a potassium 4.2, and serum chloride 98. And a urea and uric acid were within normal limits. Serum creatinine was 1.8. LFT was within the normal range, and a complete CUE, complete urine examination, was within the normal limits, and ECG showed a normal sinus rhythm.
Okay.
And the echocardiogram, official 2D bedside 2D echocardiogram was done, which showed a good LV function with an EF of around 60%, mildly dilated RA-RV, a mild pH with RV SP of around 30 mmHg, a grade 1 diastolic dysfunction, and mild concentric LVH.
Okay, good.
His urine output was adequate, and the sputum for culture and analysis, sensitivity analysis was sent accordingly. And the ventilator settings were around FiO2 was 0.4, PEEP of 6, a respiratory rate of 18, and the same expiratory ratio of 1:3, and a tidal volume was 420. Patient was being sedated with fentanyl infusion to maintain patient ventilator synchrony, as he was getting restless of sedation.
Sir, coming to the day 2, as per our IC protocol, what we do, sir, we usually stop the sedation early in the morning hours. Then his sensorium was gradually improving, sir. Like since the day of admission and day 2, his sensorium was improving. His pH was also improving slowly. The target SATs were around 88 to 92. His heart rate came down to 120, sir. And his respiratory rate has came down to 26 per minute, sir. And the ABG, which were being taken at 12-hour intervals with the FiO2 of 40, was pH from 7.34 to 7.42, and the PCO2 of from 54 to 46, sir, and the bicarbonate of 28 to 24, sir. So keeping all these things in mind, weaning initiation was being considered, sir.
Yes. So one very common thing which we encounter, every one of us encounter in ventilating these COPD patients, that most of these patients are chronically compensated. So their bicarbonate may be in the ranges of 42, 46, in 40s, and the CO2 is 90, suppose. So any overzealous doctor or intensivist will do what? They will try to overcorrect the CO2. So maybe from 80 or 92 or 120 PCO2, they will take down the PCO2 levels to maybe 40 to 50. Okay. So what life-threatening problem can happen when we, suddenly take down the PCO2 levels?
Cerebral vasodilation and the raised ICP is a possibility, sir. Second is a hemodynamic sudden shift in the electrolyte balance can lead to hemodynamic instability.
Okay. So as I told you, the correction of bicarbonate will take time. So if the CO2 levels come down suddenly, and you have bicarbonate levels in the tune of 40s, you will have sudden appearance of life-threatening post-hypercapnic metabolic alkalosis.
Yes, sir.
Yes, sir.
Okay. So that is why it is very important that we take down the CO2 gradually. And we should not be very overzealous in correcting the CO2 level. So gradually, if it comes down, maybe the correction will happen. So we should avoid post-hypercapnic sudden appearance of metabolic alkalosis. Okay, yeah, please go on.
Sir, coming to the day 3, patient is hemodynamically better with improvement of the general condition and the sensorium. His heart rate normalized to 84 beats per minute with a respiratory rate of 22 per minute. ABG was also showing resolution to pH of 7.46 and PCO2 was 43, sir, bicarbonate of 24 with an FiO2 of 0.35. and the labs were normal. And after a successful spontaneous breath trial, he was extubated and he was shifted to an NIV, sir. And during the course of hospitalization, sputum culture revealed no growth of any microorganisms. Shall we proceed?
Yeah, please.
And on the day 4, he was tolerating NIV. His drowsiness subsided, and he was on intermittent NIV therapy as portable BiPAP trial was also started, sir. His ABG was pH of 7.46 with a PCO2 of 40, sir. So he was shifted from a NIV to a portable BiPAP as he was being planned for shifting to a room, sir, from IT.
Okay, so what did you do about the antibiotic
Sir,
therapy which you started after having the negative cultures?
Sir, after getting the cultures and seeing the general condition of the patient, we have opted for switch therapy, sir. So we have de-escalated the antibiotics. We have tapered the steroids.
Okay, you tapered the steroids. So which steroid did you choose?
Sir, methylprednisolone, sir.
Methylprednisolone. Is there any specific reason?
Sir, because it has a longer duration of action, sir, on comparing with hydrocortisone.
And some literature has also suggested that there is increased penetration, lung penetration.
So, okay. And what about the duration of steroid? So, is there any specific duration which is mentioned in literature or in the books which we read, that this is the timeline we should follow as far as the
5 days, sir. Usually, various articles have been given in the past telling about 5 days and 14 days, but the articles supporting 5 days have shown a better role, sir. Okay, 5 days course will be usually have shown better outcomes.
So yes, so you were rightly talking about this. You know, everything changed in 2013 when an article was published in JAMA, you know, which was famously known as the reduced trial.
Yes,
Now,
sir.
this trial showed the non-inferiority of 5 days therapy as compared to 14 days therapy when they saw the number of re-exacerbations in follow-up period of 6 months. So there was no difference. So after that, 5 days of therapy without de-escalation, you can stop it. You know, short durations of steroid therapy, maybe till 7 to 10 days also, you can stop it. There's no need to taper. Okay.
Okay.
So here, as your patient improved well, day 4, you know, he was extubated. So maybe for maximum 5 days. And literature also does not support any single you know, class of steroid. But traditionally, we use methylprednisolone because the anti-inflammatory effect is very, very strong. And it has pure glucocorticoid action. That is the reason. Yeah, please go ahead.
Sir, coming to the day 5, patient is gradually weaned from NIV to BiPAP, during which he was kept under constant observation, and ABJs were also being monitored. He was kept on intermittent BiPAP during the daytime and continuous over night time, along with low flow oxygen therapy. His target saturation was being kept between 88 to 92%. He was advised for incentive spirometry, vaccinations, and a triple drug inhaler therapy as he was being shifted from ICU.
Very good. So what are those vaccinations?
Sir, pneumococcal vaccination, influenza vaccination, shingles vaccination, and pertussis vaccinations, DPT.
Okay, DPT. So, you know, in long-term COPD patients, you know,
And
yearly
COVID
influenza.
vaccination.
Yeah. So yearly influenza vaccine.
Yes, sir.
And, you know, pneumococcal vaccine maybe, you know, 3 to 5 years. Dr. Vijay would have been the best person. And then you have very new devices nowadays in the market for follow-up COPD patients as far as the physiotherapy is concerned. A lot of new devices where you know, graded respiratory efforts are produced.
Aerobica.
Positive, huh?
Aerobica.
Yes. One of the device, and I don't know the name. So a lot of advancements are there in home spirometry scenario. So yes, so Okay, you can move ahead from here.
So we are done with the presentation.
Yeah, so that was a perfect, very nicely presented case, and I'm so happy that both of you, uh, you know, answered most of the questions, 99% of the questions.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you, Dr. Kola. Thank you, Dr. Ravi, for making me part of this very, very interesting session.
Yes, thank you. Thank you so much, sir. Before we close the session, sir, couple of questions actually.
Yes.
One would be the role of magnesium, sir, role of magnesium in acute exacerbation actually.
Yeah. So, you start your patients on, SAMA and SABA, the short acting, in the ICUs, if we talk, in COPD patients, you start your patients on IV steroids and, short acting and the antimuscarinic agents and the beta agonist. Do everything to relieve the patients of the spasms they have. Now, the second line, once the patient does not respond to that, and the patient have protracted kind of exacerbations where the spasms are high, there the role of magnesium is definitely there as a smooth muscle relaxant. So there you can use. You can also use, aminophylline infusions, though, literature, especially the Western literature, they talk against it, and they talk about it using in the contact state patients, very specific patients where you have refractory kind of spasm. So there is a definite role of magnesium. We use magnesium very frequently in our ICU patients, but again, the level of magnesiums have to be kept in mind.
Another question from the audience, sir. This is regarding the role of HFNC, sir, in acute exacerbation of COPD, which is commonly debated again.
So if you ask me, this is more of a topic for debate. If I have a real life scenario where I'm in the ICU, I am handling my patient of COPD, I will never go for HFNC because I am very much well versed with my NIV. I have handled hundreds of patients in NIV, and again, there is a lot of debate about the kind of positive pressure we want from the NIV, the kind of tidal volume augmentation we get from NIV. It is not there with the help of HFNC. The exact EPEP and IPEP concept is not there. You have a positive pressure generation from HFNC. So it is more useful in patients where you have more of hypoxia than hypercapnia. In hypercapnia, with all of the historical evidences and the practices we had and the expertise we have, we all are very well versed with NIV. So NIV is better placed as compared to HFNC in acute exacerbation of COPD. But again, if you want to have an experiment kind of thing, maybe you can put your patients, but those patients should not be very sick. Handpick those patients, sit and stand by the side of the patient, and monitor very closely. Let me tell you that it is very jazzy to talk about all those gadgets, but when you handle patients on non-invasive therapies, it is a very labor intensive job, and you have to be by the side of the patients all the time. It's not like that in invasive, you intubate the patient, and then you can go to the next patient and relax after relaxing the patient. The scenario is different here. So yes, there is a lot of talk. People are using it. There have been a lot of literature recently, but this is my view. And if you are going for an exam, please stand by the side of NIV.
Even I think the evidence also is talking more towards NIV,
Yeah.
except in mild cases probably where we can try, but in moderate and severe, it has a very
Yes.
high failure rate. And
Yes.
the last question would be regarding the noise which is made by the echo, sir. role of ECOR in severe acute exacerbations with difficulty in like in this case probably where would we have considered ECOR when the patient was on NIV to reduce the carbon dioxide, because that was the problem what we were facing here.
So, there is an escalation ladder, if you ask me. And the ECOR stands little higher in that. And in those centers where the experience is very good, even at the centers where who are doing ECMO, this is a lot of people I talk about. They are also not much in favor and use of this. But people have devised their ways of using ECOR. Maybe I will not like to talk much about this in such a case presentation scenario. So it is a debatable thing, very rarely used. When you are stuck again there, the centers which are very well versed of using such devices can go ahead with that. There is no problem in this.
I think Venkat sir has also joined, sir. Sir, anything?
Yeah, nothing, Ravi. I just wanted to thank all of you. Very well done, well presented. Thank you, Ashutosh, being here for a long time.
Thank you, Dr. Kula. Thanks for having me here. Thank you, everyone.
Yeah. Thank you so much, sir. Thank you for joining. Thank you, Mohan, Ali, and Bilal for presenting such a beautiful case and for the wonderful presentation.
All the best from my side. All the best. My blessings.
Thank you, sir.
Omar.
Thank you. Thank you, sir.
Thank you. We'll close the sessions. Thank you.